Congratulations on considering bariatric weight loss surgery. You've taken the first step towards a healthier and fuller life. This video will explain everything you need to know.
Hi, I'm Dr. Mohammad Jamal, bariatric surgeon and director of the Surgical Weight Loss Center at Spotsylvania Regional. I completed my general surgery residency, followed by a fellowship in weight loss surgery in 2005 at the Virginia Commonwealth University. Following the completion of my training, I pursued academic surgery at the University of Iowa Hospitals and Clinics. In 2013, I joined Spotsylvania Regional Medical Center to set up the only accredited weight loss surgery program in the greater Fredericksburg region. Over the course of my surgical career, I have successfully performed over 700 weight loss procedures, including gastric bypasses, sleeve gastrectomies, lap bands, and revisions of failed weight loss operations.
We're here to help you through this process, educate you, and help you make an informed decision. Watch the seminar in a quiet area. Have a pen and paper ready to jot down any questions or notes. After you've watched the seminar, you'll receive a call from one of our staff members to discuss your first consultation, and you may ask them any questions you have at that time.
We will be discussing the background on the obesity epidemic and the rationale of weight loss surgery. I will discuss the different types of weight loss procedures offered at Spotsylvania Regional Medical Center, and of course the overall health benefits of undergoing weight loss. During the seminar, you will hear synonymous terms including bariatric, weight reduction, obesity, and metabolic surgery, which all essentially mean weight loss surgery. Let's talk about a growing problem in the United States, obesity. Over the last 20 years, the percent of Americans that are obese has dramatically increased. It is the most chronic health problem and the second leading cause of preventable death. We are seeing greater than 50% of adults, which is roughly 32.6 million people, overweight, and greater than 5% that are morbidly obese. The good news is that for individuals failing conservative treatment of obesity, surgical treatment is available, extremely effective, and sometimes the only available cure of certain obesity-related medical conditions. So what are the risks of being obese? If your weight is more than twice your ideal body weight, your risk of early death is doubled compared to someone who is not obese. Obesity leads to many dangerous health conditions, including migraines, depression, diabetes, asthma, hypertension, arthritis and joint pain, stress incontinence, and infertility. Here is the good news. While obesity used to be seen as a personal weakness or failure, it's now considered a disease with serious health risks. Diet and exercise are still the cornerstone of obesity treatment, but today, bariatric surgery may be an option for you. Now let's discuss how we define obesity. The body mass index is a ratio of weight over height and is a more accurate predictor of the class of obesity than just weight alone. The normal body mass index range is between 15 and 25. An individual is considered overweight if their BMI is up to 29. Class 1 obesity is defined if the BMI is between 30 and 35. Class 2 is between 35 and 40. And Class 3 or severe obesity is when the BMI exceeds 40. You can easily calculate your BMI with a chart like this. Just find a number where your height and weight intersect. You might be a candidate if your current BMI is greater than 40 without any medical conditions, or a BMI of 35 with at least one major comorbidity like hypertension, type 2 diabetes, or sleep apnea. A common question I'm asked is why surgical treatment is more effective than diet, drugs, or exercise alone. The answer is simple. There are numerous clinical studies that show 9 out of 10 individuals who may initially lose weight following conservative treatment of obesity will regain some or most of the weight back after stopping the medical treatment. On the other hand, 9 out of 10 individuals Undergoing weight loss surgery will continue to maintain the weight loss in the long term. In other words, sustainable weight loss is achieved in almost 90% or more patients undergoing bariatric surgery. The number of weight loss surgeries continues to increase every year in the United States, from nearly 20,000 procedures performed in 1997 to over 200,000 procedures performed in 2015. Generally speaking, there are two ways to perform weight loss surgery: open versus laparoscopic. Open surgery is performed using one large single incision, whereas laparoscopic surgery is performed utilizing 6 or 7 smaller incisions, which leads to better cosmesis and faster recovery. Regardless of the type of procedure, there are 3 important factors for success after bariatric surgery, and all of them revolve around compliance: compliant and cooperative person, compliance with the diet, and compliance with an exercise program. Non-compliance is the most common reason for weight regain after a successful weight loss procedure. Weight loss procedures fall into 3 main categories. Restrictive operations like the lap band or the sleeve gastrectomy involve reducing the size of the stomach so as to restrict the amount of food that an individual can comfortably eat, therefore restricting the overall caloric intake. Malabsorptive procedures, on the other hand, like the biliopancreatic diversion, with or without the duodenal switch, are fairly complex procedures that utilize malabsorption of ingested nutrients to result in weight loss. A combination restrictive and malabsorptive operation is the gastric bypass, which results in both restriction of the amount of food ingested as well as mild malabsorption of the nutrients. At Spotsylvania Regional, we offer the gastric bypass, lap band, and the sleeve gastrectomy as primary weight loss procedures, all done laparoscopically. The laparoscopic adjustable gastric band is perhaps the simplest weight loss operation currently available. It involves placement of an adjustable band around the stomach. By injecting saline through an attached port or reservoir, the opening of the band can be altered, resulting in a specific degree of restriction. There are some advantages associated with the lap band. For example, the overall anatomy is minimally changed, there is no associated malabsorption, and it can be performed laparoscopically as a same-day procedure. However, there are many pitfalls associated with the lap band. Most importantly, insufficient weight loss. An individual can expect to lose perhaps up to 40% of the excess weight with the lap band. More importantly, revisions of failed lap bands to a sustainable weight loss procedures are associated with a higher surgical risk.
In the case of the lap band, patients are typically discharged home after recovering from anesthesia and can return to work after about 2 weeks.
The more commonly performed Roux-en-Y gastric bypass significantly improves obesity-related comorbidities, including diabetes, sleep apnea, hypertension, arthritis, hyperlipidemia, and stress incontinence. It is a long-established method of surgical weight loss and results in restriction of caloric intake with profound early satiety. The long-term weight loss following gastric bypass is easily sustainable, and the bypass can provide almost 70 to 80% of excess weight loss. The nutritional risks following gastric bypass, including vitamin deficiencies, are rare and easily manageable. The gastric bypass involves creation of a small pouch, which is always connected to a loop of small bowel. The bypass stomach, which is not removed during the operation, is drained by a second surgical anastomosis downstream.
After having Roux-en-Y gastric bypass surgery, you may expect to stay in the hospital 1 to 2 nights, with a 2 to 3 week recovery and weight restrictions for 1 month.
The third and last procedure offered at Spotsylvania is the laparoscopic sleeve gastrectomy. This was first described as a staging operation prior to a duodenal switch or gastric bypass many years ago. This was also the preferred approach in high-risk obese individuals with BMI in excess of 50. The sleeve gastrectomy involves removal of nearly 3/4 of the stomach. The weight loss achieved after gastric bypass is very comparable to that after a sleeve gastrectomy and can exceed 70% excess weight loss. As a result, the sleeve is becoming a more favorable weight loss procedure given its simplicity and excellent results.
The hospital stay and restrictions for both gastric bypass and sleeve gastrectomy are very similar, with up to a 2-night hospital stay, 3 weeks off work, and a weight limit restriction of 10 pounds for about a month.
All patients must take lifelong supplements following weight loss surgery to prevent long-term nutrient and vitamin deficiencies. The number and type of the supplementation depends on the procedure performed.
The treatment protocol at the Surgical Weight Loss Center involves several steps. Some of these timelines may be dictated by your individual insurance plan. The process begins with an initial surgical consultation, a mandatory education class, obtaining blood tests, and a dietary consult. Patients then undergo a compliance period and any specialty consultation that may be required prior to obtaining insurance pre-authorization. In the simplest of cases, this process may take up to 2 months prior to scheduling surgery. Before, during, and long after your surgery, Dr. Jamal and the Surgical Weight Loss Center will provide the support you need for success.
You have already taken your first step by viewing this online seminar. Next, a nurse will contact you about an initial consult, and then other program staff will evaluate you on many other criteria. You will also need to attend support group meetings and nutrition classes. Thank you very much for viewing.
If you have any questions, please call us. We're here to help. Welcome to the freedom to live the way you always wanted to.